Good morning. My name is Omar Mesawri. I'm an assistant professor of medicine at UC San Diego, and I'm pleased to talk to you today about central sleep apnea. So I'll just go ahead and dive right in here. Um, so today we'll try to get through a few major objectives here. We'll describe the epidemiology and demographics of patients with central sleep apnea. We'll try to understand the pathophysiology of central sleep apnea due to heart failure and to other causes. We'll define the role of positive pressure and other treatment options for patients with central sleep apnea, and we will at the end describe some novel treatment strategies for central sleep apnea. So central sleep apnea, of course, is different from obstructive sleep apnea, both in its appearance, in its pathogenesis, and in its treatment implications. It's defined by reduction or cessation of a respiratory flow that's mediated by a reduction in respiratory effort. I think it's useful to categorize CSA as either hypocapnic or eucapnic versus hypercapnic, and others have made that observation as well. In hypocapnic or eucapnic CSA, you're primarily thinking about heart failure, chronic kidney disease, maybe other disorders of volume overload, or high altitude, in particular going from low altitude to high altitude, or complex sleep apnea or treatment emergent sleep apnea. In hypercapnic CSA, you're thinking primarily about stroke, structural brain lesions, drug-induced CSA, like opioid-induced, or neuromuscular disease to some degree as well. So we'll talk first about hypocapnic or eucapnic CSA, primarily in the setting of heart failure, and then we'll go into some of the hypercapnic causes of CSA. So the prevalence of CSA in heart failure is fairly high overall. The rule of thirds applies here, and this is from a meta-analysis in 2010 that showed that the prevalence of CSA is roughly the same as the prevalence of OSA, and so about a third of patients with heart failure will have primarily CSA, a third of patients will have primarily OSA, and the lucky third will have neither of those. What is clear is also that patients with CSA in heart failure seem to do worse. So this is an early paper that described that effect. This is a small study group, small group of patients, but they're fairly well matched for heart failure severity and circulation time, pulmonary function testing. And what you can see is pretty widely divergent Kaplan-Meier curves between these two groups with respect to whether they had or didn't have Cheyne-Stokes breathing here, central sleep apnea with Cheyne-Stokes breathing. There was also marked differences in cardiac death, in sudden death, and in the need for heart transplantation. And this has been shown in multiple other series since that time. Here's one nice paper from 1999 that showed that not only did patients with more severe central sleep apnea do worse, there was an interactive effect with left atrial area. So it's not just about the heart, it's also about the severity of central sleep apnea, and that predicts mortality. Cheyne-Stokes breathing was present in many more of the non-survivors than in the survivors in this group. These patients were followed for about 30 months. The pathophysiology is complicated, but I'm way oversimplifying it here with this diagram. But I think that this provides a useful framework to think about the pathophysiology of central sleep apnea. So you start with a state of relative hypocapnia, and this is not much. This is the hypocapnia that is needed to produce an apnea in Cheyne-Stokes breathing is just a millimeter or two below below eucapnia. So the apneic threshold, in other words, is very, very close to eucapnia. And so when that happens, you get an apnea, which then elevates your PCO2, leading to compensatory hyperpnea, and then that will, in many cases, lead to another reduction in PCO2 below the apneic threshold, and lead to hypocapnia, and the cycle perpetuates. It's often been useful for people to think about this as analogous to a home thermostat. If you have a very sensitive thermostat where a mild reduction at the set, relative to the set point. If the set point is 72 degrees and your temperature is 71.9 degrees and your furnace kicks in, then that's sort of analogous to having an apneic threshold that's very close to eucapnia here. So that can be one way that you have an analogy there. Another way is if you have a very powerful furnace where there's hyperpneas, or the furnace kicks in very strongly to then reduce the PCO2 or to increase the temperature, and that leads to an apnea or to the furnace shutting off. Something that's a little bit harder to sort of analogize, I guess, is that you might have a state where there's a delay in the relay of information between the thermostat and the furnace. So, like let's say it takes forever for that information, the furnace is on, and it takes forever for the thermostat to get the picture that, hey, it's 73, 74, 75 degrees. For it to shut off, and so you might have this fluctuation in the furnace output because of that. Similarly here, if there's circulatory delay, you might get these states where you're breathing and then not breathing and breathing and not breathing. And so I think if you think about it as sort of analogous to the thermostat, it sort of helps give you a framework for understanding the pathophysiology of Cheyne-Stokes breathing in this situation. So let's go into a question. We have a 62-year-old woman with a history of congestive heart failure due to ischemic cardiomyopathy, hypertension, fibromyalgia. She has complaints of long-standing non-restorative sleep and daytime sleepiness. She has no bed partner and is unsure whether she snores. Her Epworth score is elevated. Her medications include aspirin, Plavix, lisinopril, metoprolol, oxycodone, and zolpidem. On exam, she's mildly obese. She has a Mallampati tube airway, an S3 heart sound, and a little bit of lower extremity edema. She had an echo 3 months prior that showed both systolic and diastolic dysfunction with a left ventricular EF of 38% and left atrial enlargement. She had a polysomnogram which showed reduced sleep efficiency and severe central sleep apnea with an AHI of 41.2 events per hour, primarily central apneas with Cheyne-Stokes breathing. So the question is, which of the following is true about the patient's central sleep apnea? A, the use of oxycodone is strongly associated with Cheyne-Stokes breathing. B, adaptive servoventilation improves mortality in CSA with Cheyne-Stokes breathing and systolic heart failure. C, Cheyne-Stokes breathing is more common than obstructive sleep apnea in patients with systolic heart failure. D, Cheyne-Stokes breathing is associated with worsened mortality in heart failure. Or E, acetazolamide usually worsens the severity of Cheyne-Stokes breathing. And I'll give you just a second here to look at the choices there before we go on. So the answer is D. Cheyne-Stokes breathing is associated with worsened mortality in heart failure, and we showed that with a couple of studies earlier on. The patient has systolic heart failure and severe Cheyne-Stokes breathing. Oxycodone is an opioid medication, but not usually associated with Cheyne-Stokes breathing, although often associated with central sleep apnea and Biot's breathing, which we'll see in a minute. ASV worsens mortality in those with reduced LVEF. We'll talk about that in just a second as well. Cheyne-Stokes breathing, as we said, is roughly as common as obstructive sleep apnea and in those with heart failure. And then acetazolamide may actually improve severity of CSA in heart failure. So we'll talk more about that in a second as well. So when we're talking about the treatment of central sleep apnea for heart failure, one of the first treatment options that people look at is CPAP, and that's based on some studies that came out, the first of which was in 2005 by Doug Bradley and colleagues, where they had patients with heart failure and central sleep apnea randomized to CPAP or no CPAP with a mean follow-up of 2 years and a primary outcome of transplant-free survival and a variety of secondary outcomes, as you can see there. This is the CANPAP trial. There was a reduction in AHI nicely in those patients who were randomized to CPAP relative to control, and concomitant increases in the mean oxygen saturation and the nadir oxygen saturation. So as you might expect, it's notable that not everybody that the CPAP didn't normalize in the group overall, and the very interesting part here is that there was an improvement in the LVEF in the patients who got CPAP relative to control. So this was a mild improvement, a few percent on the LVEF, but it was statistically significant. And if you think about it, a small change in a parameter like this over a very large population probably will improve outcomes in a significant number of people. So that's something to consider as well. There are also modest improvements in exercise tolerance and catecholamine levels. A subsequent analysis, so this is the primary outcome of the study though. There was no improvement in transplant-free survival, but a subsequent analysis of this that looked at those patients specifically that had their central sleep apnea appropriately suppressed by CPAP showed that they did have a significant improvement in their transplant-free survival. So I think the take-home from this is that if you use CPAP and it's successful in improving the CSA severity, I think that strongly argues in favor of the use of CPAP in this patient population. Sort of on the heels of that, ASV was first described in 2001. ASV is adaptive servoventilation. It provides a low level of CPAP with additional pressure to sort of fill in the gaps in Cheyne-Stokes breathing. It does appear to work better than oxygen, CPAP, and bilevel ST in reducing the AHI in Cheyne-Stokes breathing. So it fills in the gap very nicely, and it seems to work fairly well. But there was this larger study that was a negative study in patients with systolic heart failure and reduced LVEF. So this is a study sponsored by ResMed of about 1,300 subjects randomized to ASV or to usual medical therapy, and the primary outcome was a composite of all-cause mortality and hospitalization for heart failure. This study completed enrollment, but a field safety notification was released around the time of ATS in 2015. I know probably a lot of us were in the room when this was announced and remember being there, showing that ASV actually seemed to induce harm in this patient population. So here's the Kaplan-Meier curve from the paper that was released, showing that mortality, or the primary endpoint, a composite endpoint, was worse in those patients who got ASV relative to those who were randomized to control. The Kaplan-Meier curves looked similar in if you looked at death from any cause and cardiovascular death as well. And then if you looked at specifically the on-treatment analysis instead of the intention to treat analysis, that had similar outcomes as well. So why is this? There were several papers that came out subsequently which looked at the data to try to tease out why patients who got ASV would do worse. And it seems to be that there's a signal for increase in mortality that's related to not having been hospitalized previously, and then also having a lower LV ejection fraction. So why did SERVE-HF turn out to be a negative study or appear to show harm in ASV? There was a significant difference in the amount of antiarrhythmics used in the ASV arm, but it didn't seem to matter if they adjusted for this variable in subsequent analysis. I think many have wondered whether this is a spurious finding and whether ASV actually is harmful. I think it's hard to argue with the Kaplan-Meier curves and with all of them going in the same direction, those nicely divergent curves in that paper. Some have wondered whether this is a direct cardiovascular effect. When you think about it, what does ASV do? All it does is increase pressure. So, can the increased pressure, intrathoracic pressure, cause a reduction in preload sufficient that it causes issues for these patients already with reduced EF? I think that's a reasonable thought. The other consideration is whether you get electrolyte abnormalities from alkalosis that results from hypocapnia. There's also a consideration of whether there are indirect effects. Are there differences in medications between groups? Are there differences in medications that are being used because of ASV? Those kinds of things. And I think that, to a large extent, we're still sort of not exactly clear as to why ASV seems harmful in this group. There was another trial that sort of was enrolling at the time that the SERVE-HF study came out. looking at the effect of ASV in hospitalized patients with heart failure. This is not only systolic heart failure, but systolic and diastolic. There was no difference in a combined primary endpoint, but the trial was stopped early due to the results of SERVE-HF. When they looked at a small number of patients that had a preserved LVEF, they actually appeared to do better with ASV. So I think there's still a lot up in the air as to how best to treat these patients. So the bottom line, I think it's reasonable to try CPAP in patients with preserved EF, but ASV is probably okay in these patients as well and may actually be helpful. Avoid ASV in patients with reduced EF, and don't forget also that heart failure management is associated with improvement of sleep apnea too. So this should never be a secondary thing that we do. Oh, maybe we'll try to optimize their heart failure. That really should be the primary thing that you try to do first, because you often get a significant improvement in patients' sleep apnea severity just by optimizing their heart failure. So medical optimization, BiV pacing as needed, and then transplant if appropriate. So let's shift gears a little bit and talk about hypercapnic central sleep apnea. This is less common than hypocapnic and eucapnic because heart failure is so common. It's due to stroke, Chiari malformations, and other structural CNS lesions. In very rare instances, congenital central hypoventilation syndrome can present with central sleep apnea. Medications can do it. Think of opioids first. Neuromuscular disease, and rarely, I think, restrictive lung disease. Restrictive lung disease itself is not terribly uncommon, but it's, I think, pretty unusual that it causes central sleep apnea. Here, I think it's more important to think of extrathoracic restriction rather than intrathoracic. In stroke, there is a high prevalence of sleep-disordered breathing. This is a meta-analysis that looked at the prevalence from across multiple studies. And the overall prevalence is very high, 60 to 70%. But most of these patients have primarily obstructive sleep apnea. It's a minority that have mostly CSA, but there are probably a lot of overlap in these patients. So 7% have mostly CSA, but many of the patients who have obstructive sleep apnea probably have some central events as well, or high loop gain or something like that. In opioid medication use, the prevalence of central sleep apnea is also quite high. In this meta-analysis, they found that the prevalence overall was about 24%, which is fairly high, and it seems quite intricately related to the morphine equivalent dose per day, the MEDD. So if you are on higher levels of these opiate medications, the prevalence seems to be fairly high. Now, the traditional approach to opioid-induced central sleep apnea has been to reduce the opioid dose. I mean, I think that it's fairly clear that that'll work. It's just that I think that many practitioners understand that that's often very challenging to do. So there have been some papers looking at the efficacy of positive airway pressure in patients with opioid-induced central sleep apnea. This is one of those papers from Shahrukh Javahari in 2014, where they took a set of patients who had opioid-induced central sleep apnea and put them on CPAP for a night, and then some of them got a second CPAP study to see if that would improve, the thought being that maybe the CPAP was itself inducing central sleep apnea, so as they got used to it, their AHI would go down. You could see that that's actually not the case. And then all of them got an ASV titration as well. You can see that ASV was highly successful in suppressing the central apnea index. That's what's plotted here, not the overall AHI. And you have to go into the table to find that the AHI was reduced in ASV, but still not normal. It was reduced by a little over 50% here, a little less successful in patients who just got CPAP. I think another interesting thing is that the arousal index was also quite high in patients with ASV. When you looked at these patients in terms of how they felt, they seemed to do fairly well with ASV, but they also seemed to do fairly well with CPAP too. Epworth scores were not different between those two groups, but both of them were better than baseline. So So ASV works in this patient population, but it's not perfect. In terms of how a patient feels, it's probably not a whole lot better than CPAP. Um, so in general terms, when thinking about treatment strategies for hypercapnic central sleep apnea, think of withdrawal of medications, maybe even the addition of synergistic pain relief. That often is helpful in this patient subgroup too. CPAP in those patients with persistent CSA can often help. A trial of ASV may be reasonable. Again, be sure that patients don't have heart failure with reduced ejection fraction. And then when you're thinking about patients with neuromuscular disease, the mainstay of therapy here, if they have significant central sleep apnea, is bilevel, non-invasive positive pressure ventilation with a backup rate, so ST, BiPAP ST. So we'll do one more question here. A 63-year-old man with a history of type 2 diabetes, obesity, coronary artery disease, hypertension, hyperlipidemia, presents with loud, disruptive snoring and witnessed apneas. The physical exam reveals a BMI of 37, monopody grade 4 airway, oropharyngeal crowding, and macroglossia. There are no extra heart sounds, but lower extremities show trace edema around the ankles. A PSG is done that shows an apnea-hypopnea index of 48 events per hour, with nearly all of them being obstructive apneas or hypopneas, and a nadir oxygen saturation of 67%, so severe desats. He started on auto-titrating positive airway pressure with a range of 6 to 16 centimeters of water. At follow-up 4 weeks after PAP initiation, he's found to have a residual AHI of 18 events per hour, and these are primarily central apneas. So the question is, so that whole stem could have been replaced with this patient has complex or treatment emergent sleep apnea. Fine. So which of the following is not a risk factor for this condition? A, male sex, B, severe OSA, C, congestive heart failure, D, use of beta blockers, or E, the presence of mixed sleep apnea on the initial sleep study. I'll give you a second here to consider those options. Okay, so the answer is D, the use of beta blockers. So a quick word about complex sleep apnea, which is also called treatment emergent central sleep apnea. It affects about 10% of patients with OSA who are started on positive pressure. It's defined as the persistence or emergence of central events upon PAP initiation. The pathogenesis is related to excessive loop gain, probably the activation of pulmonary stretch receptors, which sort of is a signal to the brain that maybe you've taken too much of breath and you need to sort of slow it down, and enhance chemoreflex sensitivity. Heart failure is a risk factor for this, and others include being male sex, OSA severity, and then having mixed apneas on the initial sleep study. So let's finish here with just a few words about other treatments for central sleep apnea that I think have gotten a little bit less attention, but might be helpful in certain clinical contexts. So the first one we'll look at is acetazolamide. This is from a meta-analysis that was just released, hot off the presses, from a colleague here at UCSD, Chris Schmickel, who looked at the efficacy of acetazolamide in those patients who had both OSA and CSA, and found that it had a pretty good effect, more of an effect in central sleep apnea than obstructive sleep apnea. In central sleep apnea related to heart failure, it was quite effective here. In patients with opioid-induced central sleep apnea, it was a little bit less effective, but in all groups it was fairly effective, which I think is pretty interesting. We don't often use this, but it probably is a good tool for patients who are just intolerant to positive airway pressure. You can see that it also was quite effective in patients at high altitude, so that's something to think about if somebody's going to high altitude for a short period of time, for example. Oxygen has also been investigated in central sleep apnea. So this is an early study that looked at 20 patients with eucapnic sleep disordered breathing. So these patients didn't all have to have just central sleep apnea, but they had to have a central AHI greater than 10. They were put on oxygen, which was titrated to reduce the ODI, the oxyhemoglobin desaturation index. And the AHI was found to be reduced in all sleep stages and positions. There's always been concern that oxygen could prolong these respiratory events. It didn't in this study. I know that other studies have have shown that there's a mild increase in apnea duration, but it's usually quite offset by the reduction in AHI overall. I have had patients that have central sleep apnea. It's in particular idiopathic central sleep apnea. They don't have heart failure, but I put them on oxygen and it works quite well. The studies show us that something like 2/3 to about 80% of patients will be responsive to oxygen. I've had a couple patients go from an AHI in the 40s to about 4 or 5 with this. And this is for, I think, again, patients that simply can't tolerate positive airway pressure, because as you can see, it doesn't work quite as well as CPAP or ASV. And then a new technique, neurostimulation in CSA. This is the so-called Remedy system that was reported in Lancet a few years ago. This is a sort of like a pacemaker. You know, you get an implanted lead in your chest, and then an implanted device in your chest with a sensing lead that goes to one phrenic nerve, and then a stimulation lead that goes to the other. And it detects whether you're not making adequate effort to breathe, whether you're having central sleep apnea, and if so, then it stimulates the phrenic nerve on the contralateral side. And as you can see, it was fairly effective, but only half of patients had more than a 50% reduction in AHI. There were improvements in sleepiness and other quality of life indices. So I think I would probably reserve this for very highly symptomatic patients that simply cannot tolerate any other therapy. I would probably try acetazolamide and oxygen before I would try this, just because of the fact that it's a surgery and it's fairly invasive, but it's something to consider. So in summary, CSA is common, but it's heterogeneous, and I think that you have to really think about CSA in terms of whether it's causing hypocapnia or hypercapnia when you're thinking about its treatment and the workup. You should consider the diagnosis in heart failure and in other diagnoses that predispose to central sleep apnea. There's no single approach to treatment. In order of the things that I would try, I guess, withdrawal of causative medications and optimization of heart failure as appropriate are always the first thing to try. If somebody's on opioids, try to get them on lower doses. Do things like nerve blocks if possible, or opioid sparing agents. If they have heart failure, trying to make sure that their cardiologists are optimizing that as much as possible. And then I would try positive airway pressure. Depending on the cause of central sleep apnea, I would do either CPAP, non-invasive ventilation, or ASV. And then oxygen if that doesn't work or they're intolerant, maybe acetazolamide, and then maybe neurostimulation afterwards. Okay, that's my talk for today. It's been very, very nice to have the opportunity to talk to you guys. I really appreciate it, and I'm happy to take any questions. So thank you.